All right. Well, welcome back, everyone. Welcome back. And thank you for the overwhelming response from the lecture this morning. As you guys well remember, this morning I introduced one of my patients, Austin, who's a 27-year-old male with ADHD and attention issues. And we kind of watched as he developed loud snoring and breathing interruptions around 15 or 16 years of age. And it got worsened until he needed MMA surgery, which I think this morning I said was the be-all and end-all. But what I meant is it's really the last resort that we want for our patients. And it was just such a privilege to be able to work with him and to hear that we've given him his life back. And so that case really underscored the fact that we're able to put out fires, and that's what a lot of the mainstream medicine is doing. And we here in the audience are so dedicated to this field that we're focused more on the smoke. And when it comes to the smoke, there's not as much evidence for it. And so the purpose of this lecture is to empower you guys to understand what evidence there is and how we can use that bit of evidence to move the field forward and advocate for our patients. And so we talked about how there's a spectrum of sleep disordered breathing that goes from mouth breathing to noisy breathing to snoring and then to sleep apnea. And we introduced tongue tie as one element in the bigger picture puzzle. And we introduced tongue tie surgery. I showed you this cute little girl, and we saw how we helped her from noisy mouth breathing to completely quiet nose breathing. And so here she is, 2 months out, this time not a lollipop, but a candy cane.
There it was, out and up, 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 out and up.
All right. So here she is at...
You got it? Did you catch it? Yes. Excellent.
All right. And so what we're seeing is that the therapist is working with a patient to restore tongue mobility. As we learned all day, it's not only about the tie, it's about the position and mobility of the tongue. And we've learned is that we have to pair our surgical interventions with post-operative therapy that's going to rehabilitate the oral structures. And so the case I showed you is a case report. And so if you show a scientist or a critic this, they'll say that this is just a case report. There's no control. It hasn't been randomized. And it's no better than personal observation or expert opinion. And so this lecture, we're going to talk about evidence. And so we'll just start at the top and talk about level 1 evidence. And so when you're coming from science, from a scientific perspective, a PhD perspective, you're lucky that you're able to do your reports in a very controlled laboratory environment. You're able to control each and every variable in order to test your hypothesis. But this simply is not possible when you're in the realm of clinical practice. One, because that's not how people grow. That's not how people live in a laboratory, highly controlled environment. And two, it's just not feasible to carry out these studies because in order to do a level 1 study, you have to really know what each one of the variables are. So if we're going to plan as a researcher a study, we can't start with the level 1s. We have to start down here and inch up the data level until we can do the level 1 studies. Okay? So I showed you a case report. And a good scientist would say that that is not evidence. We know that it's level 5 evidence. It's not controlled. It's not randomized. So when someone says to me, you don't get offended. You say, this is level 5 evidence. And then so what we do is we say, OK, that's one case. So here's another one. 11-year-old girl, very similar. Sleep disordered breathing, depressed mood issues. We release the tongue tie. A letter from the mother the next day. Michaela has so much more energy. And you can see how well she's thriving. And that's 2 cases, OK? And here's another. 3-year-old boy with mouth breathing, restless sleep, maladaptive swallow, maxillofacial development issues. And the mom messages me 10 o'clock at night. She couldn't contain herself post-op day 5. Rebecca, who's the therapist, and I always work with a therapist before and after for all my cases. Sorry for the late text, but thank you both so much. Daylon is so much better in the mornings. I am afraid to jinx it, but he is not crying. He is the baby I used to have before when he napped. He's so chatty and reasonable and happy. His sleep is already so much better. His tongue isn't even fully healed. Both of you have helped my children so much. Their lives will forever be improved, and for that, I am grateful. So what we're seeing here is that he's holding his tongue up to the roof of the mouth. We can see how he functions.
Zaghi, let's take a look at our section.
And this is the end point, to get the tongue up to the roof of the mouth
Hold that suction.
without any strain or effort.
For over 30 seconds now. Okay.
And we're going to show this more in my next lecture. We're going to go into more of the details of what you're looking for and what are the endpoints of release. And so I showed you 3 cases, and 3 cases makes a case series. So now we have level 4 evidence. But level 4 evidence still isn't very high. So what we've developed is 350 cases. And so 350 cases now makes level 3 evidence. It's still not level 1. It still only puts you in the yellow range because there's no controls here and there's no randomization. But we feel good with this, that we're on the right track. We're not harming our patients with a satisfaction rate of 88% and a quality of life improvement of 86%. And so we're going to move forward to learn more and to study what's going right in the patients that are doing well and what's not going right in the patients that aren't improving. And that's how we inch up and improve the level of evidence that we have. And so before we tell you about what we do in our practice, we're going to take a step back and we're going to look at the literature review of how and what does the literature say about tongue tie and sleep disordered breathing. And really the leader in all this is Dr. Guillaume out of Stanford. And he was my mentor who kind of lit my enthusiasm and interest in this field. And we're going to track his progress from when he first discovered sleep apnea to what he's doing now. So Dr. Guillaume is a physician and researcher. He played a central in actually discovering sleep apnea in the 70s. He was the founding member of the Sleep Disorder Center in 1975 and the first editor of the journal Sleep in 1976. Since that time, he's authored 600 articles. 600 articles. And each article builds one on top of the other to advance the literature basis. And the ideas continually change. What he thought about sleep apnea in the 1970s is different than what he thinks about it today. And so I encourage all of us, as we're doing our practice, to take a look and see how can we improve it, how can we make it better, and we can only do that by talking to each other and doing the studies to move things forward. And so over the last 10 years, he's been interested in identifying early risk factors that lead to sleep apnea and how we can prevent it. And that's where I kind of jumped on and I'm looking forward to kind of continuing his legacy of research. And so Dr. Guilleminot's career in sleep began when he was a neurologist and a psychiatrist. And he was going to different conferences, and he heard from an Italian researcher about the fact that there are some patients who snore and have high blood pressure during the night. And he went to a conference, he thought that was super interesting. And so what he did is he worked with the cardiologist in his hospital and encouraged them to spend all night watching and observing the patients in the hospital who were snoring. And he saw that some of these patients, as they fell asleep, they snored, but then they started to have a slowing of their breathing. And some people stopped breathing. And when they stopped breathing, they started to get changes in their blood pressure, so much so that it resembled as if they were doing a physical activity exercise. And then what they saw, as I'll show you, is that they did tracheostomies. And a tracheostomy is a surgical procedure in which you bypass the upper airway altogether, and that resolved the sleep apnea. Now, sleep apnea, yeah. Now, sleep apnea, snoring, they knew about snoring and sleepiness. And they call this Pickwinian syndrome, and there's this fat boy in Charles Dickens' book who's overweight, he's always sleeping, and he has very loud snoring. But it wasn't until the 1970s, it's not even that long ago, 50, 60, 70 years ago, that people even knew what sleep apnea was. And so we're talking about tongue tie, and this field is in its infancy. So how are we going to move tongue tie forward? Let's take a look, let's take a step back, and let's see where was sleep apnea and how did that come to the forefront. And so 1972, they're seeing this syndrome. They're seeing it. So then what do they do when different people are seeing it? They have a meeting. They have a conference. And that's exactly what happened. And I'll read this out to you guys. At the suggestion of a respiratory specialist and a neurologist, they came together and they held a symposium from different specialties and practices. They all came together. And they held this conference in 1972. And as a result, they developed this concept of sleep-induced apnea syndrome that results in cardiovascular consequences. And they see that the breathing issue is not only when they're awake, but it's when they're asleep. And so that they say is that they got neurologists, cardiologists, otolaryngologists, pediatricians, physicians, everyone all together to study this in closer detail. But even then, even for something like sleep apnea, you just kind of watch the patient. There were medical centers there that didn't think it existed. They couldn't see it. They couldn't diagnose it. Just like we are in our communities, where some communities, some folks, it's right in front of you, the tongue tie. But if you're not using the right tools, you won't be able to diagnose it. And the same for sleep apnea. There were people there that are saying, you're making this all up. There's no evidence for it. It doesn't exist. Sleep apnea doesn't exist. And then so in 1977, they published the first cohort of 15 patients, 1977, with sleep-induced apnea, who developed cardiac arrhythmias while they're having these apnea episodes. And they tried medical management, atropine on them. It sort of worked, but then they discovered the tracheostomy. And the tracheostomy was the cure. Here is a patient, evidence for you. The patient is having arrhythmias during their apnea, and then you do the tracheostomy and their heart rate is completely normal. And you can leave the trach open and you get you're okay, you're breathing. You close the trach so they can't breathe, and you get arrhythmias. And you open it, and they're okay, and you get arrhythmias. There's no better control trial than this. But even if you look at tracheostomy, there is no level 1 evidence for tracheostomy. A randomized controlled trial has never been performed. But if you look at it, look, pre-AHI, because you're only looking at AHI, right? It's all about what you're looking at. The apnea-hypopnea index, 70s and 80s and 90s. Stop breathing 90 times per hour, down to 0. You can't beat that. 100% treatment success. So then, in 1981, CPAP was introduced as an alternative. And at that time, there were only case series, 5 patients, versus the tracheostomy, which is proven and definitive. So if you look at the level of evidence, you have level 2 evidence that tracheostomy works. Any patient with sleep apnea, 100% success. And if you look at CPAP, you have case reports and case series, level 4 evidence. So what are we to do when the evidence, we want to offer clinical advice, but the evidence just isn't there, right? Like we saw in the earlier lecture, someone said I was nodding when they were saying that there's no evidence. There is not evidence that you should intervene early, but that doesn't mean that you don't intervene early. It means that you measure yourself and you understand. So when the person is saying there's no evidence, you're going to say, you know what? There's not level 1 evidence, there's not level 2 evidence, but there is level 5 evidence, there's level 4 evidence, and there might be even level 3 evidence. And that's where the debate should be, is how strong is the evidence, not that there's no evidence. Okay? And so where we are with tongue tie, most of the literature is level 3 through 5, and a lot of them are 4 and 5. And that's okay. It should be level 4 and 5. because Form 5 is open, you're exploring, you're getting input from multiple areas. You can't do level 1 until you've identified each of the variables. And so that's where we are. We're a field in its infancy. Sleep apnea was only 50, 60, 70 years ago. And these tongue tie issues, it's really the past 5 or 10 or 15 years at the very most, as we're going to see. Okay? So keep that in mind as we're going through. You guys are on the cutting edge. And that's something that you should be proud of, that there's no evidence. Because we're going to be the first ones that are going to bring that evidence. And this is a really exciting field to be a part of. And so really, it starts down here. This is where the exciting stuff is. These expert opinions is where you can generate hypotheses. The folks that are doing just the randomized controlled trials on CPAP versus tracheostomy, there's no new ideas that are going to be birthed out of that. So we have to use our ideas and come talk together. So now let's look at pediatric sleep apnea. We said that adult sleep apnea was identified in 1972. Pediatric sleep apnea was reported in 1976. They got 8 children, ages 5 to 14, and they saw that it was similar, but not the same as adults. It's different, okay? These kids are very sleepy. They don't do well in school. They have abnormal daytime behavior. They're wetting the bed. They're waking up with headaches, weight issues, and maybe having some blood pressure issues. And they're finding that when they have surgery, and the only surgery they're doing at the time is tonsil adenoid surgery, that it's improving it. And so this is the first description of sleep apnea in kids. Then in 1982, they find that, you know what? Sleep apnea in kids is quite different. Because sometimes they don't have any apnea at all. And they don't have any oxygen saturation at all either, unlike the adults. But still, even if they're not having apneas and they're not losing oxygen, they're still being sleepy and they're not performing well during the day. And if you take out the tonsils and adenoids, you're seeing improvement. And then, this is 1982, a big jump, 2001. This is the next study. And so this is where they describe upper airway resistance. So sleep apnea is you're not breathing, but upper airway resistance, they're saying, is even more common in children than sleep apnea. And this is where you're having airflow limitations like we saw earlier this morning. That's much more common in children, and it can impact them a lot more. And these kids with the upper airway resistance syndrome, they don't really have large tonsils. Maybe they're grade 2 or 3, but they all seem to have something wrong with their craniofacial skeleton. Then in 2004, they understand that if kids have pediatric sleep and breathing issues, you remove the tonsils and adenoids. So they went and did a retrospective cohort study, and they saw that, yes, 85% of kids do well, but there's still about 15% who have persistent issues, even if you remove the tonsils. And so this is where the attention to craniofacial issues and tongue tie and myofunctional issues was born, only 14 years ago. And so what they did is now 2011, big jump again, very, very recent. Retrospective review of 400 children ages 2 to 17. And they said, what's happening to these kids? How are they presenting? What does their anatomy look like? And how are we treating them? And so what they did in this study is they looked at the tonsil size. And so, grade 0, the tonsils are removed. Grade 4, they're touching together. They looked at the Mallampati, which kind of tells you, does the tongue fit in the mouth sufficiently? And they looked at the skeletal classification. And what they're seeing is that, yes, a lot of the kids do have large tonsils, but they all tend to have other issues as well, very common. Small mandibles, high arch palate, retrognathia. And so this is where they describe the concept that, hey, yes, it's the tonsils, but let's look at something else. Let's look at the high arch, narrow palate. That is something that we're seeing in our kids with sleep apnea, just level 4. And then, so what they did in this study is they said, okay, so if you have a narrow palate, how do you fix that? It's with orthodontia. So what should you do first? Should you do the orthodontia first, or should you do the tonsils and adenoids first? Right? And so what they did in this study is they randomized the kids to receive surgery followed by orthodontics, And in the other group, orthodontics followed by surgery. And they all followed them, and they did a questionnaire as well as a PSG. And they saw that it really didn't make a difference. If you did the orthodontics first or the tonsils first, you oftentimes needed both in order to effectively treat the patient. And then in 2013, okay, so now you have two different tools. You have ENT and you have orthodontic tools. And so you treat the kids with either adenotonsillectomy and or orthodontia as relevant. And they referred half of them to myofunctional therapy, which is restoring the tongue posture, lips together, nasal breathing, and 13 who did not pursue therapy. Of the 11 who pursued therapy, their average apnea-hypopnea index was 0.5, 0 breathing events per hour. And in kids, 1.5, less than 1.5 is normal, 1.5 to 5 is mild sleep apnea, 5 to 10 is moderate sleep apnea. And so of the kids who did not pursue therapy, they're relapsing. And so absence of the myofascial reeducation is associated with recurrence of sleep disordered breathing. And this is where myofunctional therapy is emerging, not even that long ago. We're talking 5 years ago. There may be an important role of myofunctional therapy in the treatment of sleep apnea. And in 2014, only 3 or 4 years ago, we're talking about continuous nasal breathing as the ultimate goal in pediatric sleep apnea. And this is where I got my first involvement. I was a fellow at Stanford, and I was working with Matt Camacho. And he said there's this thing called myofunctional therapy. And so what we're doing at Stanford is just objectively assessing every tool, from tonsils to trachs to septoplasty and everything, every kind of intervention for sleep apnea. And we came to myofunctional therapy. And we found that myofunctional therapy was highly, highly effective in reducing the apnea-hypopnea index in children and adults by 50 and 60% respectively, improving daytime sleepiness and snoring, and that it's effective in all ages and plays a very important role in relapse. And the goals of the therapy are very simple: lips together, tongue on the palate, nasal breathing. So the idea here is that the tongue should rest at the roof of the mouth to maintain optimal airway function. And for two reasons. One is when you have a low tongue posture, it's going to crowd, you're going to get dental crowding, high arch palate issues, as you've been learning all day. And the second issue is that when you have a low tongue, it's going to physically narrow the airway by having a posterior inferior position in the airway, physically blocking your airway. And so what does myofunctional therapy do? It strengthens and tones the tongue, and it moves to restore the tongue position up to the roof of the mouth. And so here's the tongue up to the roof of the mouth, like we showed. And here it is with naturally optimal tongue mobility in a 5-year-old infant. And we saw Dr. Marcusson describe this. This is what she's looking for. This is what you guys are looking for in the infants. Is the tongue up or is the tongue down? So where does tongue tie come in the picture? Well, tongue tie can sometimes interfere with the goals of myofunctional therapy. And it's when the tongue tie is holding the tongue down and interfering with the function that we're going to address it structurally. And so what does the literature say about frenectomies and sleep apnea? And so there's really only one paper in the literature, and that's actually from Dr. Guilleminault. And so what this study shows is there's 27 patients who had short lingual frenulum and sleep disordered breathing. And they presented with snoring, poor sleep, fatigue, but also speech, swallowing, and suction issues early in life. And so there were 10 of those kids who were referred. They had large tonsils and a short lingual frenulum, and they were referred for TNA and frenectomy. There were 8 children who had normal-sized tonsils and referred for just a frenectomy, and 9 children who were referred to the orthodontist and for frenectomy. So the kids who were referred to the orthodontist really didn't get the frenectomy. Only 8 out of the 10 who were referred for the tonsils had frenectomy performed, and only 5 of the 8 actually had a frenectomy, and they're doing a cohort study here. And so what they found is that, okay, the 8 who had the frenectomy performed and the tonsils, 5 who had isolated, and 14 did not. And so there was overall improvement no matter what they did, really. But only 2 children, and those were both the ones that had the tonsils and the frenectomy, only 2 out of the whole cohort had resolution of the abnormal mouth breathing. And 90% of the patients persisted, whether or not they had a frenectomy. And so there were 11 patients who didn't get the frenectomy and who were sent for frenectomy afterwards, and still no difference. Okay? That's what the literature is showing. That if you do a frenectomy, it may or may not improve it, unless you introduce myofunctional therapy. Because in these older children and adults, the functional issues have lingered and persisted over time, and you have to re-educate that child how to use the tongue. Simply releasing it isn't going to improve anything. So if you look at the literature and people do studies, I did a frenectomy, nothing happened. Well, you have to re-educate it. You have to get the tongue up. And that's what we're seeing in the research. And so if we were to take a look at the research, 1972 is when they discovered sleep apnea. 1976, pediatric. 1970s to 80s, they were doing trachs. 1981 is when they introduced CPAP. 1995, CPAP for pediatric OSA. 2001, they're describing more of pediatric sleep apnea. 2004, they were just doing TNAs. 2011, they were doing TNA and orthodontics, but still seeing fall-throughs. And then 2015, tonsils, orthodontics, frenectomies, and still seeing relapse. And then so where we are now, 2013 and beyond, is we're looking at myofunctional therapy as the necessary ultimate missing link. And so the research that's been done since that time, we're showing that the short lingual frenulum is a problem in adults and pediatrics. We're showing that it's a risk factor for a high arch narrow palate. And now the research that we're doing out of the Breathe Institute is we're talking about pairing frenuloplasty with myofunctional therapy in order to achieve those outcomes. And if you were to ask me, is there evidence? We're starting with level 5, level 4, and level 3, because that's the way we're going to advance the field. But if you take a look at the history, this is where it's guiding us. And so it's not only about just cutting the tissues. You want to do it right, and you want to do it right the first time. Here's a 59-year-old lady with a long history of headaches, chronic sinus infections, forward head posture, jaw tension, and cervical neck discomfort. She already had a frenectomy. They already clipped it when she was 7. But she developed all these issues. So she came to see me. She had the maxillary expansion, and that improved her sinus infections, but things still aren't right. So let's hear about her journey.
Hi, my name is Katerina Widish, and my father's really tongue-tied, can't use his tongue at all, and I had a frenectomy when I was 7 because I was tongue-tied, and it didn't make much difference. My tongue looked sort of normal, but I've had really bad headaches my whole life. I have scoliosis, a lot of jaw tension, a lot of problems sleeping, and I had been told that perhaps I should go see an oromyofacial specialist, but I hadn't done that. I actually had to do a palate expansion because I had such bad sinus infections all the time, and I didn't want to do sinus surgery. And the palate expansion helped, and it helped the headaches somewhat, but not entirely. It got rid of the sinus infections, but I still have a very small palate. And eventually after that, I decided I would go see Joy, and I would, Joy Moeller, and I would go have an evaluation. And she suggested right away when she saw how I was swallowing that many of my issues, including the not sleeping, including the constant headaches and the TMJ, might really change if I had a deeper frenectomy, that my adhesions, I don't know what you call them, were deeper in and were submucosal, and that they had not been disconnected in the first surgery. So I came to see Dr. Zaghi, and he agreed that this would make a big difference. And I had a tremendously forward neck when I came to see him. I was sort of like this all the time, and lots of tension all the time in the jaw, the back of the head, constant headaches. And the experience of the surgery was really amazing for me because I was scared of it because I'd had this botched one when I was 7. And Dr. Zaghi and his assistant were incredibly present and kind and informative so that it wasn't so scary to do. The actual procedure was not painful or difficult really at all, but what amazed me during it was I had a need to go pretty deep to cut the cords. So what was amazing to me was that the first layer of cords, I didn't feel much, and I thought, oh, I'm going to be the one person this doesn't really change. And then the second layer, I started to feel this opening in the back of my neck, in particular where the neck connects to the spine. But the third layer, when he clipped them, it was like everything in my head and back opened up. And so now you can see that the way that I hold myself is completely different. This would have been impossible before the surgery. So in 1 second, there was this feeling of, oh, everything opened up. The pressure in my jaw is gone. The pressure in the back of my head is gone. All kinds of possibilities are opening up. I've had a little bit of a dance with my scoliosis because once things started to revise themselves, my dowager's hump, which I had a really big one, gone in 1 second flat, but now the rest of my spine has to adjust to that. So I've had a couple of weeks where things keep coming and going and they're not necessarily so comfortable. However, I seem to be coming to the end of that already, so it's only been a month since my surgery. And mostly just what I feel is this tremendous expansion and a lightness in my head, neck, and jaw that I couldn't have imagined before. When it happened, I thought, oh, this is what normal people feel like. This is how easy it can be to be in the world. And the fascinating thing, because I work with people's emotions, I'm a somatic therapist, is to notice in myself how from the second that those last cords were clipped, there's a sense of ease in the world for me that wasn't there before. I'm not taking anything quite as seriously. I just have a fluidity and a sense of balance that I didn't have when I was always like this. So now there's so much possibility opening up. So I'm so grateful I've had this surgery. I wish I'd had this deeper one when I was 7 and didn't have to have this long process. So I would, to any parent who has a child, if your child is struggling with headaches or sleep problems and you know that there's some degree of tongue tightness there, if you could gift a child with what has just happened for me at the age of almost 60, if you could give it to a young one, it'd be pretty amazing to not spend your life struggling with this tension. And those of us who have spent our life struggling with this tension, to us it's normal. We don't even know there's another possibility. But to find this other possibility now is really, I don't have words for it. I'm so grateful for it. And if you have a child who might have this issue, the surgery is minimal in comparison to the gift you could give them. So I would strongly suggest it.
Okay. And so this kind of explains why we do the surgery, why we're doing frenectomies, and how we got here. And so since I have a little bit of the time, I'm going to jump to how we're doing it. And so how we're doing it starts with the assessment of tongue tie. And so this is the tongue range of motion tool. We developed it based on over 1,000 patients that we evaluated using every possible tool that has been described to evaluate tongue mobility. And so the way that we assess for tongue function is based on the tongue range of motion, tongue mobility. And so we have the patients assess their maximal opening and how much their tongue reaches up to the roof of the mouth. Now for Katerina, she started, you would think a grade 3 or a 4, but I operated on her when she was a grade 2. This patient you just heard, and we made her to a grade 1. So what's going on? How is it that there are patients who are able to get their tongue up who are still having issues? And so what we're seeing on the grade 2 is, yes, the patients are able to put up their tongue, but they're also having a compensation pattern. Okay? So just to kind of go over this classification again, as we are going to talk to you and hopefully introduce you to some of the compensation patterns. Grade 1 is ideal. You're lifting up the entire tongue with no compensation of the floor of mouth, the neck, or the attachment of the lingual crest. Grade 2, you're lifting up 50 to 80%. Grade 3 is when you're less than 50%. And we now have evidence that if you're grade 3 or grade 4, you're at an increased risk of having a narrow maxillary arch and elongation of the soft palate. For grade 1 and 2, we have case reports and case series that there are something going on there that we have to study further. And we're seeing that it's not only about the tongue up in this direction, but what's even more important is what the tongue is doing when they're in the suction cave. Okay? So here we're going to show an example We're going to show 3 patients, and I'm going to ask you guys what their tongue tie is, okay?
Guys, show your tongues. Who is the shorter for any of them?
Open your mouth all the way and lift up. Come a little closer and lift up. So it's less than 5% mobility to the tip on either one. Lift up again, open up your other way, and lift up. There it is. Okay, so these kids are not able to get up their tongue more than 25%, it's like less than 5%. So we would characterize this as a grade 4 tongue tie. Okay? Yes? Okay. And let's look at the dad. What do we see? He's got one too? That one? Yeah. Okay, and right here, lift up your tongue. And you see the dimple. And look at dad. And look at dad. And what does dad have? Dad has a grade 3. Okay? And so we did the release. And what's the endpoint, right? What's a successful outcome? So here we have them. One of the kids is able to hold up the suction all the way, and the other is not. Okay? So let's see that.
So both boys, after their procedure and the healing, have really been doing a lot better. They have a lot more mobility, and they're sleeping better for sure. And I think Jess's ADHD has really calmed down. Yeah, they just seem like happier kids.
Can I see your tongues, boys? Gus, let's see yours. Let's see your tongue.
Okay, so he's able to lift up. Okay, maybe more than 50%, maybe just about. Grade 2, grade 3. It's an improvement, but he's not done. Okay, he needs therapy, and he needs maybe a second stage release until he's suctioning up all the way without any compensation. Okay, and so any revisions that we do, we're talking. I mean, he was 0%, and now he's 50%. It's a success, but we're not happy with that. We, in our institute, are carefully studying these patients to take them all the way. Okay? And let's look at the other one.
Okay. All right, Wiley, let's see yours. Get your tongue up to the roof of the mouth.
Perfect.
There we go. That's great.
Okay? So that's our endpoint, getting the tongue up. The whole tongue, front and back. So let's look at this girl. Is there a tongue tie here? So what we're going to do is now we're going to identify compensations. Okay? So she's able to get up maybe over 50%, maybe not. But what we see is that she's straining the floor of the mouth, right? She's lifting up the floor of the mouth. She's pulling on the mucosa of the alveolar crest here, the Eiffel Tower, and she's engaging her neck. Okay? So this is still a tongue tie, and we describe this as a grade 3 compensating to grade 2 with extensive strain in the floor of mouth and cervical neck. And so the way we are classifying it is we can talk about grade 1, 2, 3, and 4. We can talk about grade 4 compensating to 3, 2, or 1. Grade 3 compensating to 2 or 1. And even grade 2 compensating to grade 1. And we're looking for the tension, floor of mouth elevation, cervical neck engagement, inability to get up the back of the tongue, low tone, problems with endurance, fasciculations, and tongue-jaw dependency. And so this is just an introduction to the functional evaluation. And in the session, we'll open it up to questions soon. And in the session tomorrow, we'll talk a little bit more about how we diagnose these functional issues and how we do the surgery. So thank you very much.